afternoon, ladies and gentlemen, and welcome to the session called Accessibility, Equity and Health Safety for All Persons despite COVID-19 and after it. My name is Luigi Bertinato. I'm the Scientific Secretariat of the Italian National Institute of Health, head of office. It's really my pleasure to welcome all of you and to welcome the four speakers which they will contribute to the session. Dr. Francesco Gabrielli from Rome, from the Italian National Institute of Health. Dr. Marco Manca, which is the president of Schimpulse Foundation. Pete Kercher, is the founder of Design for All Europe, and an architect called Consuelo Agnesi, expert in inclusive design. Why this session? Obviously, we are in as of 2020, and in a period of the pandemic, and it's clear that the world is going through, after the pandemic, a cultural, technological, and a scientific revolution, obviously speeded up by the COVID-19 pandemic and characterized by a progressive, indispensable digital transformation of the society. As usual, vulnerable populations, including disabled people, elderly people, are those who are suffering more the current situation. Accessibility for all is an opportunity that in Trieste we would like to promote, to contribute to have a better global world, thanks to the ICT opportunities which now are essential for all human beings. The session that I'm the great honor to chair will be starting by my colleague Francesco Gabrielli. Francesco Gabrielli is the head of the Telemedicine Center, National Center, which is based in Rome and based at the National Institute of Public Health. I will give him immediately the floor to highlight all these opportunities, and especially the lessons that COVID-19 gave to Italy in the use of the digital technologies to defend the healthcare system, which is universal in Italy, and values of volunteering, knowing how to change and how to protect the most fragile people, as I just said. Dr. Gabrielli, the floor is yours.
Thank you so much. Thank you for the invitation to this meeting, and thank you to Dr. Bertinato for the presentation of our work and the fact that he work only also with us during the most important, the most hype period of the lockdown we passed in the last months. For the first, let me, at the beginning of my intervention, let me introduce the National Center for Telemedicine and New Healthcare Technologies in Italy. It is a very young institution, and the establishment was in June 2017. The mission, you can read the mission we have, is to lead, to promote and coordinate the research and governance of the system of the social, for the social and care applications of the new digital technologies and the telemedicine. We are working on this development in Italy in the first period in three main subjects. The first is support local projects. The center are working essentially as a consultant for the local public healthcare organizations. And the center supports the constructions of new services or the improvement of old services in order to develop in Italy the best practices in each region. At the same time, we coordinate the national initiatives that are essentially works of group and group of works at the same to study and debate specific issues to elaborate steering national documents to face them. For example, the improvement in the cybersecurity for healthcare systems, or the methodology to the cost-effective analysis of the telemedicine services that is one of the most relevant issues for Italy in this period for our situation, and the develop of a professional community. We are acting essentially to allocate researches to make sharing experiences using web tools, conferences, training, and so on. The strategic goals we have is the development of an Italian telemedicine model. Why Italian? Because we have a specific system in Italy. Our healthcare system is based on the beverage model financed by the general taxes, and we have our healthcare systems have to be distributed, and the services have to be distributed to all the citizens independently of their situation, their economical or social situation. And moreover, our system is regionalized. So there are some issues that can be faced directly by national institutions like the Health Ministry and so on, and the National Institute of Health too. But other issues have to be faced by the regional authorities. So we have to try to succeed in obtain an equal and performing way to collaborate between the national and the regional institutions. During the COVID-19 pandemic, and especially in the first period, in the most difficult period in March and April, in the next March and April, we elaborate this document concerning on the television healthcare services in the health emergencies caused by the pandemic. You can easily write an English version from our website. You can digit for the download. It's simple. You can simply digit COVID-19 telemedicine English in the banner of the research machine in our website. You can forward to directly to the file in PDF. let me show some points of this document that summarize our experience, and then I try to show you what we really learned in these experiences, the dramatic experience for everyone. This slide shows you one of the figures that you can read in the document. In this figure, we summarize the organization, the model of for the organization of the telemedicine services in the emergency situation, in the COVID-19 emergency situation. And this model is applied as a whole, or is applied in a specific portions. For example, we can use also the type 1 or the type 2 or the type 3 only, or a combination of the different type of services. The type 1 is telesurveillance, means that the surveillance, medical surveillance, medical control at home of persons without symptoms, but in lockdown period. The type 2 is a telecontrol of a medical telecontrol of patients who develop symptoms or signs concerning compatible with COVID-19. The same is a telecontrol, the type 3. Type 3 service is the telecontrol dedicated to the patients with chronic diseases. The same as the type 3 is telecontrol system like type 2, but is quite different because the type 2 is standardized, because we have only to measure some parameters and not more. But in the chronic patients in the type 3 model, in the type 3 system, we have to face very different situations concerning the different chronic clinical situations of our patients. And the type 4 is a telepsychologist, as we named this service. It means that we have the possibility to share, to communicate not only in audio but also in video communication between persons forced to stay in their home because of the pandemic, with psychologists that support them in their problems or in their situation. Let me stress another point. In this model, as you can read, there is the two possibility to switch from one type to another, from one type of service to another type of service. Type 1 is the more simple, if for person without any symptoms or signs. Type 2, if for person with simple symptoms related to COVID-19. Type 3 is person who have symptoms of COVID-19 and also specific chronic situation, clinical situation. One of the most important things that we learn, and that we can summarize in this table. For example, in the type 1, person without symptoms or signs, it's not necessary to have a very expensive telemedicine system or a very a smartphone of the last generation system, a very complicated platform, software platform. It's easy to monitor with a common thermometer the body temperature that can be referred to the physicians in several ways. So that just only for an example, to tell you just an example of it. We can read the other in the next lines of this table, the heart rate, the respiratory rate per minute, and so on. So, in summary, we learned that flexibility can be organized starting from medical procedures better than technological innovations. This is an important key point to underline, especially in emergency situations. As a consequence of these flexibilities, we increase the trust of professionals in our systems, in telemedicine offered system, but we noticed also that the trust of patients comes from the relationships with the physicians overall, more than the trust in the technological innovations. And this is also another key point, because we have not only to organize a perfect system from a technological point of view, a safety system from a medical point of view, we have also to organize a system that have the possibility to be really accepted from the patients, by the patients, sorry. But there is all this that doesn't mean that there isn't any organization. That it doesn't mean that organization is not important for the telemedicine services. Of course, the base of telemedicine development, you know, is the multidisciplinary approach, because we have to work together with engineering, with computer scientists, and so on. But we can organize flexible services, even if we have we've appointed a right, an appropriate attention to the organization. That you can read study deeper this scheme in the document. In the next, in this slide, we have to. I try to summarize one of the most important lessons we learned concerning on the data, on the use of data, of the clinical data, healthcare data in general meaning. If we work this study in, you can read in JAMA, in this study, you can read that the authors summarize our situation now concerning on the development of bioscience. We are in a moment in which the biomedical research are changing because of the possibility of new use of the data. But it's not so simple in the reality. Theoretically, is all is correct, this approach. But in a practical field, we can observe a sort of interruption or a sort of breach in this scheme between the part above and the part below. The part above is real now. We have the possibility of collect data from population, individual, organ tissue, cell, and so on. But the possibility to really use in service development and in research this data is not so easy, because we have to pass some, to face some issues. At first, we based our possibilities in developing research, in developing new services, in the so-called Internet of Things. It's easy to tell what does it mean in Internet of Things. It's easy to tell that it means to organize and facilitate interactions between different devices using the Internet. But it's not so easy in reality, as we know. We need the certifications for medical devices. And we have, for example, it's simple for an ECG machine, device, but it's not so immediate to understand how to certificate a new app for healthcare. And the broadband is quite important overall the territory in a nation. You know, in Italy we have a particular orographic situation in Italy is that it's very difficult to cover the same broadband in each territory. And the interoperability platform is another key point. We need the development of adequate platforms in which we have in which we can really share the data we have concerning just one person when we have the objective to care him or her. But at the same time to manage data from medicine research, medical research, and also in the governance of the systems. The interoperability is, in my vision, is one of the most important scientific, technological achievement that we have. But often we have some difficulty to explain what does it mean in reality. And I often use this method to the imagine of the train to explain the importance of the interoperability. The train have certain measures, and if you arrive at the border of your territory, and we discover that the other person, the other organization, the other region that have another type of train, in that day you will discover that you are not able to collaborate with the other, to work together with the other. So we have to plan the adequate interoperability strategies to improve the collaborations between healthcare systems, not only into a nation, but also at a European level or at the global level. Why not? Other problems are the laws. National and regional laws. This is a problem that we have in Italy, because in Italy we have regions that has the right to public new laws concerning other care, and we needs, of course, the coordination of these laws in order to offer the same level of the same quality level of the care services in all the territory in Italian. But more or less the same issues we have also at the European level, to harmonize, in order to harmonize the healthcare laws in the different nations. Medical guidelines. We need the medical guidelines to understand, to prove what we exactly perform in safety and efficacy, in order to defend the safety and efficacy also in the telemedicine services. But to arrive to define medical guidelines means that we need more clinical trials on telemedicine. If you observe the amount of clinical trials in telemedicine, you will discover that they are not so. They are very few comparing with the other field. Technical standards. We need the technical standards, but this is a minor problem because we have more or less technical standards for our field of action. So at the list, another issue is that we need a real provision of telemedicine services, not only experimental one. It's more useful to provide a telemedicine service with a low-cost technology than try to follow the most important, the last development of technologies without offer any real service to the people. When we are able to make this red pathway that you can read in this slide, maybe we will able also to adequately use the cluster computing, the cloud computing, and also the artificial intelligence in a new data-driven biomedical researches. Thank you for your attentions, and please, if you have an idea, do not hesitate to contact us. Together we will find a way to collaborate. Thank you.
Thank you, Dr. Gabrielli, for the lessons from Italy on the use of digital technologies. Some of the input you gave us, they will be included at the end of this session in the so-called Trieste Charter for Accessibility for All, which is an initiative that would like to keep the topics and the highlights of these sessions and to provide the topic to the media, and is an initiative jointly organized by the National Institute of Health and Federsanità ANCI Friuli, Venezia, Giulia, which represented in the region hosted by where the Trieste is the capital. It's a sort of coordination between the municipalities and the healthcare system. And so the idea is really to overcome barriers and frontiers thanks to the information and communication technology. And it's really my pleasure now to move to the next speaker, Dr. Marco Manca, which is president of Shimpulse, to highlight and to try to understand what innovations in medicine we need after COVID-19 to guarantee fair access, but also the safety and efficacy of health services. Dr. Manca, the floor is yours.
Thank you, Luigi. And I would like to thank the organizers for inviting me to talk today, to join this conversation. So, why innovation and why COVID? First of all, I would like to reflect on what innovation means. And often there is a collusion of the idea innovation and invention, but innovation is actually what happens when something is introduced in a community, in a market. It's an emergent phenomenon. And well, discussing what are the desired innovation can be extremely tricky, just like thinking that gardening is possible by just making a list of the plants we will want to buy. There's a number of challenges in behaviors you want to facilitate, governance rules, but I will get there. And well, why it's interesting to discuss innovation during COVID? This is a epidemic curve updated to 2 days ago, and I think it's rather clear we have been caught off guard, let's say. How did it happen? Well, some of these vulnerabilities which we would like to tackle are our complete guilt, if you allow me. I think we all remember not long ago, I think not longer ago than 10 years ago, universal health coverage was a huge issue, a very hot topic to discuss how to achieve it and what this would have meant for the world. But this interesting survey of the progress published on Lancet just last week, if I remember right, tells us that basically every progress has stopped. So we are not really investing our forces where we know they should go, and where our talks seems to go. And another issue that I think is a side effect of something we all consider extremely desirable is the fragility of our systems in the face of globalizations. Even risks that usually would be perceived as extremely remote, whatever it was, whether it was the pangolin or the bats that everyone considered the culprit at the beginning in China, or although strains of this disease seems to have appeared independently earlier in Spain, it's clear that the world is extremely connected, and we all have to be together in responding to crisis. But back to the point of innovation. So why would such a crisis be a good moment to think about innovation? Well, first of all, because in the face of these risks, many of our even most trivial daily activities have sort of changed values, and they have changed meaning for us. So think of the trivial action of shaking hands, or well, sneezing, I think it's the name, in public. And here there are images of tools that have been proposed to use interfaces that are analogic and extremely familiar with every one of us, and we have never really considered the risk. And this is amplified by the perception of uncertainty that our imperfect response has induced in the population. These are just some cartoons, but they give you the temperature of the public opinion on COVID and the current situation. And this is an image I have absolutely loved. So COVID has uncovered our willingness to do the craziest things, if you want, to try to protect ourselves and our societies, our families, our communities. Although at the same time, and this image is there really because of this conflict, let's say, it has also demonstrated that if communities, if us, even I, we are left to our own devices, we tend to choose trade-offs between what we are willing to change first and what we are resisting to change, and the uses and habits that we are willing to take later can be rather irrational, rather ill-posed. So during the response to COVID, we have seen some fantastic examples of, I could call them innovation, that have been used to good goals. And Taiwan, I think, was a fantastic example. Their digital minister has galvanized the hacking community into cooperating with the ministry. There has been a very fruitful open data transparency operation between the ministry and the communities have proven to be able to design very quickly, in a very agile manner, interfaces, data gathering strategies, and even coordination strategies that have in the end driven Taiwan to be one of the most, if not the single most effective country in responding to COVID. And we have seen, very similar to what Gabrielli was describing before, extremely good example of what I would call low-tech innovation in telemedicine. Like this was published on British Medical Journal. It's a sort of checklist guide to performing remote assessments in primary care by phone. So without even the use of any smartphone or camera or whatever. These tools are considered, if they are available, of course, they add to the performance. But just having a bit of experience with the communication and the kind of reactions, questions can trigger proves to be extremely effective as a tool. On the other hand, I have in my mind lots and lots of examples of poor performances from our community. We have entered the loop during COVID of performing science by proof of principle, of trying to push every hint of understanding into policies. This has been, I'm sure, extremely confusing for many people. There are stories like hydroxychloroquine that will be, I'm sure, mentioned in the textbooks of medical research, clinical research for the decades to come. And we have demonstrated a naive desire to pursue technical solutions, forgetting the systems. This is extremely important. Now, this piece I mention here, I share some texts that I found more interesting, more attractive, but the entire piece on ventilation that appeared on Vox was extremely well written. Just captures one of these, the desire to ignore the fact that when something is undesirable, sometimes you simply have to avoid it. And this sentence, if you have got the odor of manure, don't try and ventilate to get rid of it, get rid of the manure, was really pragmatic and fascinating to me. Of course, we have a lot of technology for ventilation that is fantastic. We have HEPA filters, we have MERV filters, I think they're called, the classification of filters depending on their percentage of particles eliminated between 0.3 microns and 10 microns. But the true point of this is we lose the idea of the complexity of the phenomenon we are discussing. And ventilation is a fantastic example. As instance, you can have a perfect ventilator with a airflow that will guarantee your 6 times per hour change of the volume of your environment. And the airflow could bring material from an infected person to an healthy person nearby before being aspirated outside. And this is, of course, something you would like to avoid. And the solution is not in studying a better ventilation system, probably, because another point is no one is able to model airflow in spaces that are not sealed. So if people can open doors to enter and go out, if we have the ability of connecting rooms that were not connected, or if the ventilator is not working constantly and it generates turbulences, nobody can tell you what will happen in that room. And thinking that the solution is only technological fails our mind. Then we also had issues that are ICT issues, and I think they are not strictly technological issues, and so they are not strictly technological innovations that we want to facilitate, that we want to pursue, but they have been in our use of the technology. Now, internet, the web has been terrific in connecting everyone and making information free to flow. And of course, in this freedom, there's the continuous human research for information, the attempt to establish whether a suspect, an idea is true or not. And on the web, these we have learned can conflate into echo chambers and other sometimes even malignant mechanisms of espionage. And this generates behaviors in the population that are hard to control. There's even a Wikipedia page fully devoted to misinformation only related to the COVID pandemic, which is only this year. In 2019, we were not even thinking about it. It's fantastic to see the enormous list of these, but we have all heard about accidents of all sorts, even people trying to drink bleach because somebody had suggested in a boutade, I hope, that this could have worked for their prevention. But there is a guilt also on the side of institutions. Institutions sometimes misunderstand the value of information beyond its content. Now, I liked this graph because the author has been, for several weeks now, he has been following the reports of deaths, specifically in Florida in this case. And he has been moving around the timeline, the deaths, to the time of death, to the actual time of death, but he has color-coded them according to the time of announcement. Now, clearly, if you see how the waves of announcements are arranged, you can imagine that the look of the pandemic, if you are modulating the information over the days, is completely different to your population. And it's honestly extremely difficult to imagine a population that complies and acts with care if you are preventing them to know how the data look like. Everyone has been looking at Sweden as an example of a very well-behaved population that has been acting maturely and even without any order to restriction has been self-restricting. But we forget that in many regions of the world, data are not available to people to understand how they have to be sensitive in the regions or not. I don't think we could be doing this graph for any city or region in Italy. And then there is another issue on our side. There is an issue of the models we have decided to use. Now we have at the beginning of the pandemic, I remember this was discussed for a while. I don't know if this is still a hot topic any longer. The SEER model or the SEIR model or whatever other derivative we want to discuss. They imagine our societies as gas tanks, basically, and then they make estimates of how the epidemics is going to behave, ignoring any form of structure behind it. Now, we do have the mathematics and the computational tools to build models that consider networks and that consider multi-layered networks where there are social networks of different environments, schools, work, local region, and that could also consider local transportation constraints. And we don't do it. And I don't think we have a very good justification for not doing it today. For months, there have been a lot of physicists or enthusiastic hackers that have been trying to propose their own models and emulate the community. But the community has been depending on very old models, and these tend to fail our expectations time and time again. Now, this story is just funny, this in my slides, but we have all seen in April forecast of the peak coming, being updated every second day. And then we have demonstrated another issue, another thing that could be, I'm not saying solved, but tackled in conjunction with ICT tools in the form of, as instance, decision support tools or even forms of machine learning support tools. The fact that we tend to neglect the asymmetric value of anecdotal information. So if we learn from an experiment of one person with a mask, that a mask is protective in his experiment, this evidence should not be exaggerated. Because the single experiment could have ignored a lot of variants, and we cannot generalize this experiment itself. But if we discover that, as instance, there has been a chimney effect in a toilet and the aerosol has contaminated an airplane, we don't need to run a trial to understand that this risk, even if it happens twice and would not be generalizable, is already enough that we want to prevent it. So in risk management, positive and negative informations don't hold the same value. And also here we are demonstrating at the governance level a number of shortcomings. Again, ICT could be of enormous help in tackling problems of transparency in this on this front too. As instance, all the stimulus money or whatever you want to call them that have been invested in COVID response around Europe, how much of them have been made accountable? Do we know where they have been spent and what they have produced? I mean, I can mention a number of large, very visible actions that did not produce anything, and I think I have read an estimate that less than 5% of all the money spent in Europe in the actions to promote innovation and response to COVID have actually been documented. This is a terrific pity, because it's not a technical inability to collect information. It's a unwillingness to make this technology easy to use and mandated, maybe. And this brings me to another issue that has been impairing, in a way, innovation, the cost charade. So we have been discussing the alternative costs of responding or not responding to the pandemic, and this has proven basically to be a worthless conversation, because the costs are the cost of the disease. If people get scared, if market trust goes down because there is a disease that can kill my grandparents, even if it's not killing myself, the market is of course going to crunch. And the point on the costs should not be a conversation on whether or not we should respond. And this should not surprise us that we made this mistake, because well, in a lot of academic economy publications about the costs of global warming, one of the reasons why the costs are minimized is because business happens indoor, which should make us all laugh, right? Because I mean, what's the point that it's happening indoor when outside there will be a tragedy of ecological proportions? And so the economic reason, the economic conversation we should really have is about inclusion. And again, I don't think we can imagine that we will sort out that one measures is going to be the perfect trade-off for everyone. Okay, I've seen many versions of this celebrity home joke during the lockdown, and in a way it's true. Denmark, as instance, has made a modular policy for schools in which the ideal for them is teledidactics. However, whoever is able to prove that this is unfeasible for them because of economic or infrastructural or social reasons, school offer them safe spaces, safe havens where they can study, not in groups. And then, because children still need sociality, they have co-opted public parks so that children can have a calendar of meetings in open air with their classes. And this way, they are not looking for one solution for everyone. They are trying to cut out solutions, yes, solutions that will fit everyone, minimizing the risk altogether. And this brings me to my last slide. In innovation, governance is extremely important. If we want to talk about innovation, we should not go down to the level of the single inventions that we like or dislike. And I love this story because at some point in the 90s in the US, they tried a lottery for telecommunications, and the lottery system was very quickly played because a lot of the winners were simply gaining access to resources and not producing anything. That's why today we try to study governance as gardening, to weed out the practices we don't like and incentivize the practices we like, instead of letting the market behave on its own. So thank you. We have, I think, terrific opportunities, but we need to rethink our governance.
Thank you, Dr. Manca, for the convincing list of examples of innovation, transparency, misinformation, cost charade. I think you gave us an extra contribution that will be included in the final chart with the list of examples that were really impressive. The time is running, so I move quickly to the next speaker, Dr. Pete Kircher. It's an Anglo-American who has been living for more than 40 years in Italy, working as a consultant in strategic design and communication. It's really the founder of the European Institute for Design and Disability, which is now called Design for All Europe. He was driving the IEDD Stockholm Declaration to define the new concept of design for all. And I think that today, after or during the pandemic, it's the input from Peter Kircher on design for all and urban planning. It's quite important and relevant. The question is, it is possible to protect everyone from infections? Pete, the floor is yours.
Thank you. Thank you. I'd like to thank the organizers for the invitation and also for putting together this rather interesting panel. It's been extremely encouraging for me to hear the two previous speakers. Let me say, first of all, if I may correct just one thing, I'm Anglo-German, not Anglo-American. I have lived in the States, but I'm half English and half German. Never mind, that's only a small personal detail. It's been very interesting for me to hear the words of warning from Dr. Gabrielli that advise us not to put our faith entirely in technology. And I took to heart very, very strongly this message that he gave us about the importance of increasing trust in the relationship with the general practitioner and in prioritizing medical procedures over IT innovation for the type 1 cases that he discussed. I think this is a message that needs to get out there also into the community, into the IT community as well, and to enable the public at large to realize that this is not something that is external and imposed, but that there is very much a partnership being proposed here. Now, I shall go into my presentation now. My organization has been around for just over a quarter of a century now. I'm actually co-founder, not the sole founder. I would love to have the merit of having been the founder of EIDD Design for All Europe, but that merit goes to the late Paul Hogan, who left us just a few months ago, a gentleman from Dublin who was a designer and also a sufferer of multiple sclerosis, who put his two fields together and came up with the response that design really could do better than it's done until now. This, of course, though, was back in the 1980s and the early 1990s. I'm having difficulty in changing the slide here. My slides are not changing. Okay, here we are. My first step is that I want to express my challenge, and I'm also very alert to the fact that the word challenge was used by Dr. Manka earlier on rather than problem. Far too often I hear the word problem being used to express what I consider to be a challenge. It's not just a matter of semantics. My challenge is to protect as many people as possible, respecting their needs and their aspirations, their human diversity and their individuality, and taking all these factors into account. Now, it is of primary importance that we realize that what makes us human are those aspirations, not our needs. We share our basic needs with most other living beings, with the mammals, and also with the reptiles. They are to eat, to drink, to sleep, to breathe, to defecate, practically. These are our needs. Our aspirations are what make us human. We ignore the aspirations of human beings at our peril, because that would reduce us to no more than automatons. And so it is most important that everything we do takes those aspirations into account. And we do so, as I say, it's a challenge and not a problem, because, speaking from my particular field, designers are creatives. Creative people react better to positive stimuli. Problems are negative. Now, it may sound just semantic, but believe me, there is a lot of human psychology in this background as well. I'm going to talk now about what design can do, because it's important for us to realize that design is not a magic wand. It doesn't and cannot and should not be expected to solve everything instantly. Design is a very important methodology, and what design can do is to adopt an holistic approach to this entire challenge. Now, design is not limited only to products. Design is pertinent to places, by which I mean architecture and urban planning, for example, the places that we exist in, the places where we cohabit, the products that we use within those environments. And that's what we call product design. The communications, because if we don't communicate between ourselves and about what we are doing, then the good designs will not function properly. So we have communication design, graphics, interfaces, wayfinding, web. I'm sure everybody in the audience has had some experience when following road signs that suddenly one sign is missing from what ought to be a logical sequence. And this means that the wayfinding has not been designed properly. The installation has not been designed so that we, as the users, have a seamless experience of finding our way from where we are to where our destination should be. Of course, that's just an explanation of one example, but I like to use examples which are not too specific to the design community, because otherwise I would be speaking to my navel, and we do that far too often. But what I want to do is to make my messages clear and understood to people maybe who function on a different level. The next thing is services, service design. It may occur that we don't always have the best experience of service flow when calling a call center. This can be improved by ensuring that it's properly designed to provide a positive experience. This also encourages good customer fidelity, fidelity also in users. For example, this can be of extreme importance with telemedicine. And systems. We also design systems. Again, optimizing customer or patient flow through complex systems, so making the best result of customer and patient experience. The method I propose is design for all, which we have defined in our Stockholm Declaration of EIDD back in 2004 already. This was one of my most important intentions when I was serving the organization myself as president. To ensure that we would have a clarity of semantics and a clarity of messages. Design for all is designed for human diversity, social inclusion, and equality. I'm encouraged to hear these words being used by the other speakers already, the importance of recognizing human diversity, because that is the reality of who we are. It's the reality of our world. It is incumbent on us to design for the reality of human diversity and not to expect people to fit into watertight containers, preconceived watertight containers. We've come a long way since Henry Ford said you can have any color of the Model T as long as it's black. We need to do better, and we can do better. Social inclusion is absolutely vital if we are to solve the issue of COVID-19 and also be ready to tackle any others coming up in future. And equality of the result and equality of opportunity is most important as well, because we must bring the public with us, and we can only do that by demonstrably showing that equality is taking place and that there is no such thing as one law for some and one law for the others. How do we achieve it? Again, in our Stockholm Declaration, we say that the practice of design for all makes conscious use of the analysis of human needs and aspirations and requires the involvement of end users at every stage in the design process. This means that we actually consult. We do not try to make one design that fits all. Design for all does not mean one size fits all, nor is it design in mere compliance with standards. Now, I'm going to pick up on another one of the points made by Dr. Gabrielli beforehand, when he talked about interoperability, which I would translate also as being conformity of standards. It's clear the place where these rail gauges changes is on the border between France and Spain, or between Central Europe and what used to be the Russian Empire back before the First World War, where the different gauges meet, and there used to be quite major difficulties in changing the rolling stock from one system to another. But in the same way, we need to have standards that govern the availability of 4G and in the future 5G telephony all over the world, and plugs and sockets. You know, if I carry my plug with me to charge my telephone, I also need to be able to plug it in to an available socket. These are the things where standards are absolutely vital, but woe betide us if we stop there. The standards are the baseline, and they partner hand in hand with the stipulations that we find in the United Nations Convention on the Rights of People with Disabilities. But we need to go beyond that. It is our task to ensure that we use our creativity to answer those human aspirations that I mentioned before. Now, the question, how can IT and ambient intelligence contribute to the design agenda and vice versa? Well, the first thing I think is to realize that designers are not just people who give a pretty face to existing technologies. I'm not blaming anybody. Designers in many respects are themselves their own worst enemies because of the way that they communicate about design, which tends to have a mass image of something that is luxurious, expensive, superfluous, and not very useful. That is a very mistaken impression. Italy is the country in Europe that produces the finest and best machine tools, which you will never see advertised or demonstrated or illustrated in the design magazines. And the reason for this is because, of course, the end user, the end client of those machine tools is probably not somebody who would buy that sort of design magazine. Knows where to go and appreciates the effect that a very good and coherent design can have on a machine tool. This country is also the country that leads the world in things like dentist chairs. Again, you don't find those advertised very much in the, or glorified or celebrated very much when we talk about design. But this is the kind of design that is of absolute essential importance. So it is clearly not just a pretty face given to the existing methods or existing technologies. On the other hand, technology is one of many variables that are of vital importance to the design process. Sometimes a really important one, a major one, never the only one. Variables also include such things as the access to broadband that Dr. Gabrielli mentioned beforehand. I'm speaking to you today, not from my own office, because my broadband stopped functioning over a week ago. So I had to come to a rapid arrangement to be able to speak to you from a different location. In times of COVID-19 and afterwards, we cannot afford this kind of breakdown, especially if you consider the fact that I live in the countryside. I live on Lake Como. We have a social and economic interest in a country like Italy, but not only by any means, to maintain people living in the countryside and not focus everybody in the cities. It's also been one of the effects of COVID that people wish to return out of the cities into places like mine where there is maybe a small garden or some possibility to circulate, even in cases of lockdown, to circulate outside in the fresh air. It's extremely important also for people's peace of mind and spiritual well-being to be able to benefit from such things. But this does not match at all with the fact that we have rather poor broadband coverage. So this is a major challenge that really needs to be solved. Designers and IT developers, in an ideal world, should work together to create custom IT solutions to meet real situations for real people, with real aspirations. Sorry, my PowerPoint has a glitch there with the word situations written twice. I'm sure you follow the reasoning though, because our principle must be, as our slogan, one of our slogans in our organization says, people come first, and design's function is to provide the responses. Can it guarantee 100% protection for everyone? The simple answer is no, but neither can technology. There is no such thing as a 100% guarantee. That is partly because we are human beings and we are irritably non-rational. We are not rational people. We are not rational animals. We do illogical and stupid things. Design has to make allowance for things like that. If you design a table that is going to be used in a public environment, you probably better make sure that it will take the weight of people stepping on it and dancing on it, not because that's what you think when you're designing it, but because that is a secondary use that may be made of it. And if you don't take that into consideration, you may find yourself on the receiving end of a lawsuit because it breaks down and someone breaks a leg. In a democratic society, then, we cannot guarantee 100% protection for everybody. And good design, even the best design, will not function if it is imposed top-down. People will resist imposition, and that is why the design for all approach is vital. So what alternatives can design offer in democracy if long-term imposition is unsustainable? Well, our process envisages the following steps: the acquisition and the analysis of all the variables, the patent ones and the latent ones, that is, the ones that are obvious and the ones that do not immediately meet the eye, that you only acquire by reading between the lines. You get that by consultation with experiencers, by analysis, more consultation, listening, learning, co-creation, verification, always more consultation, and repeated modification. Design then is not just the product, design is the method. Consultation, when I say it, it is not just questionnaires and boxes to tick. and consultation and involvement generate a sense of identification with the results. That is absolutely vital. If we don't generate that sense of identification, we might as well not bother with starting. Every product, no matter how good, will remain an imposition without that sense of identification and will be perceived as such. It will be resisted, even though all common sense tells us it should not be resisted. And recent experience with face masks is a very good example of how that works. If we intend to maintain a functioning, sustainable democratic society, design and technology must collaborate with experiences to generate that sense of identification and maintain it credibly. To paraphrase Caesar's wife, it must not only be credible, it must be manifestly credible. My apologies to anybody who was expecting to have 15 minutes of beautiful photographs about good design. I could have showed you Fabrizio Bianchetti's door handle, which is designed to be opened with the elbow without the need for any add-ons, so that people who don't have the strength in their hands can open a door with an elbow as well. But I didn't want to show you specific solutions because they would only be relevant in the context of specific perceived challenges. Since one size does not fit all, and one solution is never good for all situations, that would have been a misleading message for me to give you. Good design then is the coherent consequence of a coherent method. And today my primary concern has been to discuss method. And thank you very much for your attention.
Thank you, Dr. Ketcher. I think was absolutely impressive, the role of architecture, and we definitely agree that people come first. And I'm using your sentence to connect the final section, the final presentation, which is the Trieste chart for accessibility and health safety for all, due to the fact that Dr. Consuelo Agnesi, she was unable to connect with the session. So I will go straight to introduce the chart. And I have to, okay. Just one second. The idea of the chart is to leave a strong message to all people that were attending the sessions, but also to the media people, but also to all scientists involved in EASE of 2020, and also to those who are responsible of communities, municipalities, because the idea is that the information technology, artificial intelligence, telemedicine, robotics, and domotics can be available immediately to all people, mainly if they are disabled or a part of vulnerable populations. Just one comment about the background. The Federation of Municipalities of the Friuli, Venezia, Giulia region, where Trieste is based, and the staff of the healthcare systems, 3 years ago, they set up a list of conferences to highlight first the importance of robotics in the city of San Vito al Tagliamento, and they left a message taking home with the name of the municipality on promotion of robotics in the new paradigm of integration between hospital and territory, followed by the Charter of Udine on domotics, beyond home automation towards a life without barriers. And finally, in 2019, the Trieste chart that was to overcome barriers and borders with the use of artificial intelligence and technological innovation. This year, the charter will focus on accessibility and health safety for all. And in line to overcome barriers that hinder access to services, and also to make the best use of digital technology in daily life, as well in scientific programs. There are 9 actions and key points that I introduced to you for you to comment and for you to contribute. The number 1 action is healthcare systems have to manage change in process, turning the introductions of innovation and consider innovation as an opportunity. This action number 2 is that all local health systems must be enabled to benefit from the contribution of technologies available for healthcare, but also for social care, investing in personal education, healthcare, social care staff, and inviting stakeholders' participation, including the civil society. The action number 3 is to remove causes of inequalities, to equitable system development through the appropriate use of telemedicine services and digital innovations for all citizens. The action number 4 is to support the governance of services innovation that should be evaluated on how it's delivered on inclusion, mobility, and overall quality of life for the most vulnerable citizens. The action number 5, it is necessary to deepen the knowledge of digital tools and the situational awareness for all stakeholders for the correct governance of their introduction and working. Number 6 action is institutional representatives, which probably are in the room, and stakeholders have to make effort to avoid the risk that the lack of technological skills and economic resources, combined with strong digitalization of services, will create additional barriers and exclusion factors. And after COVID-19 is really unacceptable. The action number 7, the removal of barriers to access the services required a multi-sectoral and multidisciplinary approach that was highlighted during this relevant session. The action number 8 is more complicated because there is devoted to policies dedicated to the use of digital telecommunication technologies, so artificial intelligence, digital innovation. They have to facilitate people with disabilities, and they should focus on organize independent center to monitor and promote the implementation of a global dissemination in line with the 2006 Convention of the Rights of Persons with Disabilities, investing in research and innovation, making available the necessary resources in an equitable way to obtain resources that can really be used in daily practice. Focus on the result of the intervention as well on the quality of the procedures, and also investing in the total removal of architectural, technological, bureaucratic barriers, the so-called zero barriers, the transition to a paperless healthcare organization and to the social care projects. And the number 9 action, at the moment is the last, but can be not really the last, professionals in the research and development, as well in innovation fields, are encouraged to make available the most advanced digital solution in a spirit of equity and partnership with the local authorities, in example, municipalities, public and private health or rehabilitation structure, and the latter should embrace best practices in public-private partnership and promote and incentivize fair and public benefit-oriented intellectual property management practices. So, the Charter of Trieste on accessibility to services for all persons called all scientists, all media people, all sitting representatives of the civil society on promoting the dissemination of the Charter that will be evaluated in 2 years' time. Officially international call for interest to participate in the final version. So there is room to contribute for maybe 1 or 2 more actions, and you will be really called to include what you think is missing. We would like to organize some focus group, virtual focus group in the next weeks or months. We would like also to set up a scientific advisory board to follow and evaluate the chart, to set up a method to submit amendments or additions, and to have in Leiden in 2022 a final consensus meeting on the chart that will be probably called Leiden Chart. So if you have a further contribution, you can send an email to my email or to Federsanità ANCI, to really a colleague, Tiziana Del Fabbro, that she was behind all the building of the chart. I've finished my presentation and I immediately ask my colleagues, Dr. Gabrielli, Dr. Manca, or Peter Chair, if you have any comment on the chart, because we are 4 minutes before for a short discussion before the conclusion of the session. So, dear colleagues, there is any reaction to the chart? Dr. Gabrielli, Dr. Manca, Dr. Kircher?
If I may,
yes.
As the audience no doubt will have noticed in the presentation on one of the slides, it is specified that the Charter is approved in its current state with the scientific collaboration of my organization, the IDD Design for All Europe. And I want to underline the fact that this has been a very serious process for us. After my own input, I subjected the draft charter to my colleagues on the executive board, and we have taken a formal decision to approve this document. And we will take all the necessary steps to disseminate this document also in our own community, the design community, and in our contacts in various different directorates general in the European Commission, and so on, and in the many different countries where we work, both inside Europe and in the rest of the world, because in the last couple of years we've expanded outside of Europe into the Far East, into Australia, and into Latin America. So I want to express not only the full approval, but our enthusiastic greeting of this this initiative, and I look forward to receiving feedback from the audience and from other people. Thank you very much.
Thank you, Dr. Kircher. Other colleagues, they have any comment from Marco Manca or Francesco Gabrielli? Okay. If not, it's my role to conclude this interesting section with a lot of input from the speakers on accessibility, equity, and health safety for all persons despite COVID-19 and after it. I personally really enjoyed a lot the session, and I will go back home with a lot of new input. And I've also to thanks really from my side all the organizers, the speakers, and those who they were behind the session to make possible this virtual session. Thank you, everybody. I look forward to see you and to have input from all participants across Italy, across Europe, and outside Europe. Thank you very much to everyone. Enjoy the evening, enjoy Trieste, the last day of ISOF 2020 in the city of Trieste. Arrivederci.